Okay, so we will begin. Uh, Welcome all. From today, that is on 7th of February, we are starting webinar series on legal and MSCA issues. So this is the first session of this series. So I welcome you all. And now I request President Madam, Nina Madam, to give the welcome address.
Yeah, good evening, everybody, and a warm welcome to Legal and MHCA Subcommittee's first session. And we are beginning on Dr. Nagapurkar's birthday, and he is also the chair of the subcommittee. So, a big happy birthday from IPSWZB to you, sir. And
Thank you,
we are going to talk on a very important topic today, which is boundary violation in psychiatry. And in today's litigious times, I think it is essential to understand the ethical principles which could be violated by the boundary violations, like which include beneficence, non-maleficence, autonomy. It is a part of our practice every day, and so extremely important for us professionals to know what could be the legal ramifications if there are boundary violations. So I'm sure we're going to learn all about it in today's session, and I really congratulate the legal subcommittee to start with such an excellent topic and an excellent speaker. So over to you, Bhalchandra, for the proceedings.
Yeah, thank you, Madam. Yogendra, please show the slides. Yogendra, slides, please.
Yes, sir. I have shared, sir. Can you see it?
Okay, for this session, we have two speakers. Dr. Nagapurkar, sir, we fondly call him Yuan, sir. He is from Nashik, senior psychiatrist, and he is the immediate past president of IPS West Zone. And second chairperson is Dr. Kumawat, sir. He is from Thane, senior psychiatrist, and he is the authority in legal issue in Maharashtra as well as in West Zone. So I request Dr. Nagapurkar, sir, to introduce the topic and two speakers also.
Yeah.
Yogesh, slide दाखव ना.
Thank you, Dr. Bhalchandra, and I welcome you all for this inaugural CME of this year on medical legal aspects. And the topic chosen is quite unique, unusual, but at the same time very important: boundary violations, and which is unfortunately not taught in our curriculum regularly. So we need to be sensitized about this, and may not be physical, but even social and psychological boundary violations would we should be careful about. And for this topic, I think Dr. Netto, who is my teacher in BG Medical College, is a very apt person. He is a consultant psychiatrist practicing in Pune. He is associate professor at BJ Medical College and Sassoon General Hospital and MIMH. He is also chairperson of Forensic Psychiatry and Law Specialty of IPS, field editor, Indian Journal of Psychiatry. He has been teaching undergraduate and postgraduate students since last 18 years. He has special interest in forensic psychiatry. He was there in Yeravada Central Prison from 85 to 90, and from then Sassoon Hospital from 1990 to 97 and 2007 to 15. Also worked in Regional Mental Hospital. He has a lot of publications, and he has been participating in various teaching courses and workshops. And we have been attending since last 4 5 years his forensic psychiatry symposium in Pune. Recently, few months back, we had a very good experience which everyone could have regarding this forensic psychiatry. And I hand over proceedings to Dr. Netto sir for Dr. Netto, sir.
Yes. So,
Yeah, you can share
I'll
slide
be
from your
sharing
end.
my screen now. Just come 1 minute. I'm sharing the screen. Acha, then I go to this. Yeah.
Yeah,
Can
it's visible now, sir.
you-
Yeah.
Yeah. Okay.
Yes, yes.
Use this. This one. I'll reduce it.
Netto, sir, you need to be a
Yes.
little louder.
Yeah. 1 minute. Yeah. So just a little correction. I'm professor at Medical College, Pune, and at Maharashtra Institute of Mental Health, and I'm a consultant psychiatrist. That biodata of mine was a little old. I don't know how it's in circulation. Okay. So a big thank you to Dr. Neena Samant and Dr. Umesh Nagapurkar and Dr. Kumawat and all the stalwarts of the West Zone who have given me this privilege to speak on this very interesting topic, boundary violations in psychiatry. Now I'll begin with a case reports. And after that, I'll go to discuss what boundary violations are, some basic rules, the statistics and various studies, and the forensic aspects of boundary violations. And with me after this, I have a 2-minute video on boundary violations, which I'm sure you'll be very happy to see. So the first is my case report. Miss G, a 34-year-old attractive single woman diagnosed as borderline personality disorder with drug abuse, seeks treatment for severe depression. Her psychiatrist is recently divorced, a 49-year-old male. His ex-wife was an attractive, talented artist who ran off with another artist. He uses alcohol now and then to tranquilize his grief ever since his wife left him. He looks forward to meeting Miss G at her twice-weekly sessions, finding solace in his own loss. For 2 months, the treatment boundaries remain intact. Then gradually the sessions take on a conversational and a social tone. They address each other by first names. The psychiatrist discloses facts about his divorce and talks at length of his wife's infidelity and betrayal. Miss G feels sorry for him and is guilty that she cannot be of any further assistance. Initially, they sit at a comfortable distance from each other, but they gradually move chairs closer and finally end up sitting on the same sofa. Miss G describes her childhood physical and sexual abuse, and sessions are extended for 3 hours, which disrupts the psychiatrist's schedule. She gets tearful. He puts his arms around her. Miss G is grateful for the special attention she is receiving. They start meeting at a park. He also helps her with her bank-related work and starts making day-to-day decisions for her. He stops billing her for the session. They gradually get more intimate. They have drinks and dinner together at her apartment. On some occasions, they have sexual relations after they have had some drinks. A few days later, when the psychiatrist was on a vacation, Miss G takes an overdose and is hospitalized. She is treated by another psychiatrist who gets to know everything that happened. 1 year later, Miss G brings a lawsuit to the psychiatrist for malpractice. Now here we have what is called the slippery slope syndrome, described by Simon and Gabbard. What happens? Like you go for a toss or you slip, the therapist's position of neutrality is gradually eroded little by little. They address each other by first names. Therapy becomes less professional and more social. The client is treated as someone special, as a confidant. The therapist's self-disclosures occur about current personal problems and fantasies about the client. The therapist touches the patient, progressing to hugs and embraces. The therapist gains control of the client by manipulation of transference and negligent prescribing of medication. Extra therapeutic contexts occur, like going for walks together. Therapy sessions are rescheduled for the end of the day. Therapy sessions gets extended in time for 3 hours. The therapist stops billing the client. The therapist and the client have drinks followed by dinner after session. Dating begins. The therapist and client have sexual relations, and a lawsuit against the doctor follows. So this is the slippery slope syndrome. Let none of us get down this path. The famous author Robert Frost, he said that good fences make good neighbors. So you can see when there are good boundaries, the neighbors talk very nicely, there's no arguments, no quarreling. But then there are rigid boundaries where the walls are high, you cannot get in. It looks very uninviting. And then you have the unmeshed boundaries where you don't know where is the end and where is the beginning. So we need the healthy boundaries. As a psychiatrist, we need to show empathy, compassion. We cannot have rigid boundaries. We need to have healthy boundaries. So healthy boundaries needed, not rigid or not collapsed boundaries. Now, what are boundaries? Boundaries are limits making the distinction between two persons or realities of space, time, roles, culture. A boundary crossing is a deviation from the classical therapeutic activity that is harmless, non-exploitive, and possibly supportive of the therapy itself. A boundary violation is harmful to the patient and constitutes exploitation of the patient. It may arise from both the therapist or the patient. The purpose of boundaries is to keep the patient and therapist safe. Now we see the relationship continuum. On one side, there is a professional relationship. On the other side, a lover or a familial relationship. For maximum professional effectiveness, the needs of the client are primary and therefore boundaries are fixed. Whereas in a lover or in a familial relationship, mutual needs are primary, boundaries are variable, and this allows for maximum mutual intimacy. Now, there are various factors that come to play in the dynamics of boundary violation. One is transference, counter-transference, dynamics between an authoritative figure, here the doctor or the psychiatrist, and a person who turns to this authority. The authority figure is the therapist or the teacher or the doctor. So boundary violations don't happen only in psychiatry. It happens in all professions. Idealization. The major issue is the patient's idealization of the therapists. Therapists who are experiencing personal problems may use the patient idealization consciously or unconsciously as a means of narcissistic repair. Now, there are some important issues in boundary violations. One is the rule of abstinence, duty to neutrality, fiduciary relationship, and respect for human dignity. The rule of abstinence: the therapist must refrain from obtaining personal gratification at the expense of the patient. The fee for professional services is the only material satisfaction received directly from the patient. The duty to neutrality implies that the therapist must not interfere in the personal lives of the patient, thus preserving the patient's autonomy and self-determination. Fiduciary relationship implies that the therapist must act always in the best interest of the patients. Now, what should a person or a therapist do if he feels he's got all mixed up and he's involved in a serious boundary violation issue? His options would be obtaining consultation, speaking to another trusted colleague, seeking supervision, entering therapy, or referring the patient to another therapist. The words of Sigmund Freud are very powerful. The therapist must recognize that the patient falling in love is induced by the analytical situation and is not to be attributed to the charms of his own person, so that he has no grounds whatsoever for being proud of such a conquest, as it would be outside analysis. Frieda from Reichmann, the famous German psychiatrist and analyst, she said, "Don't have sex with your patients, you will only disappoint them." Now, who are these vulnerable patients? Every patient is vulnerable to psychological damage from therapists who commit boundary violations. Psychotic and borderline patients especially are particularly at risk for psychic injuries, so beware. There are therapists who also are likely to commit boundary violations. Sometimes the reasons are very innocent, like a recent bereavement in the family. The therapist has lost someone near and dear, or he's had a breakup, a divorce. And of course, more serious issues like personality disorders, substance abuse, alcoholic abuse in therapists, mood disorders, patients or therapists with psychotic disorders, and various paraphilias. Among these, frotteurism is supposed to be high on the list, which is a person who's got a compulsion to touch people repeatedly. Now, coming to statistics for sexual boundary violations. There is one study by Pope et al. In 1988 which says that 8.3% of male therapists and 1.7% of female therapists had sexual involvement with their patients. Another study by Gorek et al. In 1989 said 80% were between male therapists and female patients, and 13% were between female therapists and female patients. Another study, American National Survey of Psychologists, found that 87% reported attraction to the patient and 63% felt guilty or anxious about it. 4.4% reported having sex with patients, 7% male, 1.5% female therapists. 17% of therapists expressed their sexual feelings to the patient, but only 1.3% acted on them. 50% discussed their feelings with their supervisors and 20% with their own therapists. 22% of therapists referred the patient outside to another therapist. This is an American survey. As you can see, these are all foreign data. 65% of those who had been sexually involved with the patient felt that they were truly in love with the patient. 92% believe that the patient was truly in love with them. Again, foreign statistics. Now, there is a study which took the opinion survey regarding post-termination sexual relationships between therapist and client. In a survey of 4,800 therapists, 68 favored total prohibition, no sexual involvement at all with any patient. Some allowed a waiting period, and some said they should go for a non-sexual relationship if so desired after the therapy ended. Now, this is a very interesting study done by our very own psychiatrist, Dr. Sunita Kurpad from Bangalore. An enormous postal survey was done among psychiatrists and clinical psychologists in Karnataka and regarding boundary violations. And they found that 29% had reported taking gifts from patients, 20% becoming friends with the patient, 18% accepting free services from the patient, 14% socializing, 14% again undue disclosure of self to the patient, 2% inappropriate unnecessary examination, and 2% inappropriate touch. And she concludes that non-sexual boundary violations and sexual boundary violations do occur in India. There is a need for urgent attention, but disagreement on what constitutes boundary violations on some aspects in the Indian culture. I know there are some therapists who would not accept from their clients even, say, pedas or sweetmeats on a festive occasion, which is very common in India. So, is that a boundary violation? Now, when a therapist has sex with a client, the reports are this leads to a therapist-patient sex syndrome. Fear, shame, guilt, self-blame, confusion, paranoia. But the most serious is self-harm and suicide. Now, the therapeutic client sexual relationship has varying effects. 90% reported symptoms. Very rarely there is occasional benefits. And sometimes the therapist's marriage breaks up, leading to separation, childbearing years, loss of income, loss of spouse. Now, coming also to non-sexual boundary violations. Time, for instance, the beginning and ending of sessions. Starting or stopping late or early are both boundary violations. Place and space, the therapist's office or hospital unit is obviously the location for all therapy. However, accompanying a patient to court for a hearing, visiting a patient at home or in jail after an arrest is not a boundary violation. Some more boundary non-sexual violations. Money. The professional fee is the only appropriate money allowed. Anything excess. Clothing. Excessive revealing of frankly seductive clothing worn by the therapist. Self-disclosure about personal and private matters. Being over-familiar. Taking expensive gifts from the client. Sometimes even small gifts from the patient may raise the expectation of patients from their doctors. So, potential non-boundary violations. Excessive self-disclosure, special fee arrangement, low fees or no fees at all, extending time beyond what is initially agreed, allowing telephone calls between sessions, extra therapeutic business relationships, socializing with the patient. Now, very important, when Dr. Ajit Bhide was the IPS president, they came out with what we call as the IPS guidelines, or the Bangalore Declaration, or the Bangalore Declaration, if you want to call it now. The Indian Psychiatric Society convened a task force on sexual boundary violations in 2015 and submitted guidelines, which is referred to as the version 3.4. This is known as the Bangalore Declaration. They are loaded on the National Medical Commission India website. What does it say? It is the ethical duty of all doctors to ensure effective care of their patients. The guidelines are gender neutral and serve as a guide for doctors of any gender and to protect patients of all genders too. Doctors should ensure that they do not exploit the doctor-patient relationship for personal, social, business, or sexual gain. Consensual sexual activity between patients and doctors irretrievably changes the therapeutic nature of the doctor-patient relationship. Consent in a power imbalanced doctor-patient relationship is not to consent. Any non-consensual sexual activity would amount to sexual abuse, molestation, rape, and the doctor would be answerable to the law of the land. The Indian Penal Code already has laws for rape, child abuse, molestation, etc. Relevant sexual history and physical examination in the presence of an attendant. The examination findings should be documented. If treatment requires the patient to be sedated, especially a female patient, like electroconvulsive therapy or anesthesia, a nurse should be present during the induction till recovery. And this is a very big thing. A minimum time frame of 1 year should elapse after the doctor-patient relationship is terminated, after which it may be permissible for a doctor to marry a patient and enter into a sexual relationship. They caution that non-sexual boundary violation can slip into sexual boundary violation. All doctors need to be alert to warning signals in themselves and in the patient's behavior. Doctors are reminded to use social media responsibly, as it can lead to blurring of professional boundaries. The guidelines extend to protect the family members of patients too. Any failure to follow the guidelines, if reported to the Indian Psychiatric Society, will be referred to the Ethics Committee. These guidelines are extended to all interactions with students, colleagues, other professionals in the multidisciplinary team. False allegations can occur. It is important for doctors to be alert. The Indian Psychiatric Society recognizes that sexual boundary violations are not restricted alone to doctors, but occurs in all professional groups. So how can we prevent boundary violations? Foster psychological separateness of the patient and confidential. Informed consent for all treatment and procedures. Interact verbally with the patient and minimize physical contact. Ensure no previous, current, or future personal relationship with the patient. Preserve the therapist's anonymity. Don't talk about your personal self. Establish a stable fee policy. Provide consistent private and professional setting. Define the time and length of sessions. Measures for reducing the risk of boundary violations: improve awareness, allow supervision, allow managing of allegations, encourage hospitals and medical societies to implement the guidelines. How do we manage boundary violations? Ensure authorities investigating boundary violations are trained. Be aware of false allegations. Manage the patients, the victims safely and effectively. Manage the offending doctor compassionately but effectively. He may need support to handle consequences of legal action. Ensure legal advice for all patient, victim, offending doctor, and third-party doctors. It is better to report to the hospital committee. And patients also have a choice to make a complaint to the local medical council or the Medical Council of India. And if it's a serious matter involving criminal nature, they have to go to the criminal justice system. Now, coming to the forensic aspects, the Medical Council of India, now called National Medical Commission, in their Chapter 7 says that adultery or inappropriate conduct rendered by a physician will be liable for disciplinary action as provided under the Indian Medical Council Act 1956 or the concerned state medical council. Section 354 on sexual harassment: unwelcome physical contact, sexual favors, pornography will be liable to 3 years of fine or both. 3 years rigorous imprisonment. Making sexually colored remarks will be punished with imprisonment, 1 year, fine, or both. Both are cognizable and bailable. Now, outraging of a woman's modesty. Before the punishment was 2 years, now it has been reduced to 1 year. Not less than 1 year, maximum 5 years. Before it was cognizable and bailable, now it's cognizable and non-bailable. Disrobing of a woman, criminal force, 3 years imprisonment, 7 years may be extendable till fine, cognizable, non-bailable. Stalking a woman, 3 years and fine, and subsequent convictions, 5 years and fine. Now we must be all hearing about the POSH Act, Prevention of Sexual Harassment Act. The Prevention of Sexual Harassment at Workplace Act of India mandates every organization to define their sexual harassment policies, prevention systems, procedures, and service rules for its employment. You must have heard of the Me Too movement in India. The Me Too movement in India brought to light numerous allegations of sexual harassment and assault and helped to raise the awareness of the issue in the country. However, progress has been slow in terms of holding the perpetrators accountable, with many cases still tied up in legal litigation. So it doesn't stop with Me Too, it's now Him Too, the Him Too movement. This is a social movement supporting male victims of sexual assault and false allegations. Started when a mother found that her son was afraid to date because he felt the climate was all ready for false rape allegations. So, in response to the Me Too movement, the Him Too movement was also started. So I've come to the end of this presentation, after which I will show a small video. My take-home message for all my viewers here would be, healthy doctor-patient boundaries are needed. Boundary violations may be sexual or non-sexual. Non-sexual boundary violations may descend to sexual boundary violations. Awareness needs to be created about boundary violations. Boundary violations can be prevented. The Indian Psychiatric Society has given guidelines. The National Medical Commission of India has laid down rules. The Indian Penal Code has laid down punishment for boundary violations of a criminal nature. Boundary violations need to be evaluated in the Indian cultural context. Thank you for your patient listening, and I will ask Dr. Soham here to put on the video. So,
नेशनल कन्वेंशन फॉर मेंटल हेल्थ अवेयरनेस।
क्योंकि यहाँ पर अभी भी स्टिल लोग ये समझते हैं कि दिमाग की प्रॉब्लम होना बहुत शर्म की बात है।
इधर लेट सकते हैं?
नींद आ रही?
नींद ही तो नहीं आ रही है कई हफ्तों से। एक्चुअली मेरे यहाँ आने का मेन रीजन वही है। बीच आज इधर बाहर सेशन करेंगे।
क्यों? नहीं प्रॉब्लम?
मुझे कोई प्रॉब्लम नहीं, बट ये अलाउड है?
किसकी परमिशन लेनी चाहिए?
आई डोंट नो, कोई रूल्स वूल्स नहीं होते क्या? प्राइवेसी, बंद कमरा, काउच एंड ऑल दैट।
देयर आर रूल्स, बस ये जानना जरूरी है कौन से रूल्स तोड़े जा सकते हैं और कौन से नहीं।
Jack, do you want to get a cup of coffee or something?
No. Time's up.
अगला सेशन बंक तो नहीं करोगे ना?
ये हमारे सेशंस का आखिरी हफ्ता है। कैसे मिस कर सकते हैं?
So, now that this is over, क्या हम बाहर मिल सकते हैं? Just as friends or something.
नहीं, this is not possible, Kaira.
और अगर आपसे मैं कहूँ that I like you, I need you.
Kaira, जिंदगी में जब कोई पैटर्न बनता या कोई आदत बनती दिखाई देना, तो उसके बारे में अच्छी तरह से सोचना चाहिए। Genius is about knowing when to stop. Okay then.
To our chairperson, for the rest of the proceedings. Thank you.
Yeah, thank you, sir. Thank you, Neto sir, very much. Sir, it was a very lucid and informative sessions. I think new as well as the old uh, experienced psychiatrists will also help from this session. And it was actually a very general neutral session. So there are a few questions. I will take this question from the chat box. Dr. Garima Patel is asking that does helping patient over the weekend by messaging answers to whatever the patient asks is a boundary violation?
Uh, um, one minute. I didn't get the question clearly.
Does
What
patient
is the chat box? Can we just check? Can we... 1 minute. I'm just
she is asking where
Yeah.
whether the helping patient over the week by messaging answers to whatever the patient asks is a boundary violation. Many times we need to reply to the patient's message on WhatsApp or whatsoever they mean. So whether it count as a boundary violation.
Yes, if the messaging is very over familiar and not related to the patient relationship, you know. So there are many things happen. Just recently, I had one patient of mine, a young lady, and she started sending me so many things about her cooking every day and all. So I thought this is very strange. But I told her and messaged her and said that my mobile is a business contact mobile and message only for appointments or things related to the medical profession. Later on, I found that she was in a high, she was in a manic episode, and then I had to treat her. But you should try to limit it only to the treatment issues, to making appointments. Also, especially doctors, I know some of them even charge for, online, whatever, but it may just dilute your relationship. Patient will be messaging you the whole day, and when he comes to your consultation for his session, you won't know what to talk to him about because everything is already discussed.
Yeah. Thank you, sir. But sometimes it becomes very difficult to say no to the patients, especially in the Indian context. And many times we attend marriages also, patients invites us. So how and when to say no to such situation?
Yeah. I do understand it's not easy. I remember once, weddings, you have to be careful sometimes because sometimes the patient introduces you to his partner or whatever, or her partner. And if she has not told the partner she was taking some psychiatric treatment, it can lead to a problem. They will find out that she is a patient being treated by you. And they will go back and say, were you taking psychiatric treatment and all that? It can create a lot of problems. So in general, I don't go for weddings of patients. Even I was told by my senior mentor, was the late Dr. Admiral Dineto, that we are not duty bound to attend the funeral of a patient, say, who committed suicide or whatever, because again, they may want to keep it quiet, private. So I would say, as far as possible, if it's your patient, don't dilute the relationship. But of course, if it becomes so compelling, then be very careful when you go there and do your job and come back fast.
Okay, sir. Thank you. Can you see the chat box, sir?
Yes.
So there
there's
are more questions, so you can answer that also.
There is by Dr. Kailas Selvi. When a doctor couple who we know for a long time asks us for therapy, do we agree to it, sir? It will depend. See, I would say as far as possible, if you know people already in a relationship, like, in a friend relationship or they are family friends, it's very difficult for them to share with you, say, their marital discord or their sexual life and whatever. So it's better to ask these people to go there. Another thing is, sometimes if the patients are your friends, then there is a tendency not to charge them. So that's a boundary violation. It becomes very, very unprofessional. So beware, you have to take a lot of caution. When there is another question, does taking sessions outside a clinic amount to a boundary violation? I would say that it depends on what session is that. Suppose you make a home visit to a patient who is in a psychiatric emergency or is in a drug reaction or something like that, then it is okay. But if you are just, taking a session, walking on a beach, or I would not say that's being professional, For instance, suppose if there's a young therapist male walking with another young girl on a beach, it may create a confusion that whether they are in a love relationship or they are in therapy, I hope I've answered that. There is another, okay.
Like in Dear Zindagi, I think they have taken cinematic liberty for that.
Yeah.
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 Thank you, sir.
Yeah.
Now I ask Dr. Kumar sir to summarize the session and give us take-home message. Over to you, Dr. Kumar sir.
Well, thank you, Dr. Neto, for a very lucid presentation. In fact, you covered every aspect of crossing the boundaries. Doctor-patient relationship as such is a very tricky or slippery surface. It's a peak of iceberg phenomena when you said that Indian figures or Indian context about the sexual violation, etc. Actually, we don't know the figures, and many cases, like in cases of POXO, many cases don't come to the notice. And we need to be very careful, as you rightly said, about issues of transference. And the transference issues becomes when the patient demands concessions, odd times or extra times in therapeutic sessions, then offers gifts to us or invitations to any kind of private social functions or family functions. Well, you also talked about sharing drinks or meeting outside the professional setup. And this is very essential that is the place where generally this kind of violation of the boundaries happen. As a doctor, we need to be very vigilant, or as a therapist, we need to be vigilant, because not only in NMC, but even in CPA, even in MHCA, and as you rightly mentioned about the Bharatiya Achar Samhita, that is old IPC, that there are provisions for penal action against us, and this also affects the reputation of that particular person. Particularly, we have cases with a paranoia, and they have a tendency to make mountain of a mole, and even if you touch them without consent, they may tell or they may give a different version outside. So even in such patients, it is advisable that they have somebody, or we have somebody with them, and then they communicate or we examine them, etc. We also talked about the sexual boundary violations. These sexual boundary violations about the vulnerable class of patients. We have multiple elements in mental health itself, where the patients are quite vulnerable. And yes, rightly, that we need to be very careful about communicating, inspecting such patients, and then we see to it that such kind of boundary violations should not happen in this way. So overall, a good way of informing about what are boundary violations, what are the risk factor in this, and how we prevent it. So thank you very much for this lucid presentation, and over to you, Bhalchandra.
Thank you, sir. Thank you very much. So I will do the final job. That is vote of thanks. I thank President Madam and Secretary for allowing our subcommittee to arrange this webinar. So this is the first session of the webinar series, and we will be conducting more 8 sessions in this webinar series. I also thank all the EC members for their full cooperation. I thank Chairperson Dr. Nagapurkar sir and Dr. Kumar sir for their time. I also thank Dr. Netto sir. He has agreed and started the webinar series very aptly. Thank you, sir, very much. Finally, I thank all the audience for taking time to be a part of this session. So thank you all and good night, and see you in the next month for the next topic.